Alright, so right now we're going to talk about the second monitor in the PowerPoint presentation, the art line. Since we started with the blood pressure cuff. So the art line, obviously not used as much as the blood pressure cuff, more invasive, takes more technical skill. So kind of begin, something that you can do like beforehand. You see them in the pre-op is the modified Allen's test. You can kind of practice on yourself here too. It's to see kind of which artery would be better, you know, the radial or the ulnar when placing this line. So kind of clench your fist and then kind of press down on both arteries here and then relax and release on the artery that you want and watch the blood return into their hand. And if one side is better than the other, then you go into that side. You more kind of patent artery to choose, especially in the older population, you know, if they have the heart disease, because most people who are going to be getting this are going to be more kind of at risk to where you need the beat-to-beat knowledge of the blood pressure. So kind of diagram there. A couple slides on just kind of the basic how the art line is constructed. Teflon. Shouldn't use 5mm syringes we talked about way back in the beginning. Have small syringes generating large pressures. We don't want to damage the vessel. So kind of multiple diagrams here. There's a lot of information that can be gleaned from the waveforms of the art line, just like the waveforms from the end-tidal CO2 and the waveforms of the pressure volume loops. So several diagrams and several examples of different health conditions as far as what you can kind of determine, because not everything will be diagnosed beforehand. So kind of here, if you look, so the systolic upstroke, we have the left ventricle kind of punching the blood out here, and then it makes mention of, so you have kind of your first peak here, and then you can see kind of a second peak. It's kind of the augmentation pressure, kind of gives an idea of the compliance in the arterial system that you're working with. The incensura, or the dichrotic notch, is kind of that backflow when the aortic valve closes after systole and the diastolic runoff. All this, as far as the specifics of the waveform, gives you an idea of if there's aortic stenosis, aortic regurgitation, and compliance will change the pressure of the waveform and shift. And there's examples in here of all those states. And as you get older and compliance decreases, then the shape of the diastolic runoff changes. It's much more smoother. Versus a young person, you have that classic, inflection points down. So several examples for you to look through and kind of be familiar with. Main one's aortic stenosis. So some information under transducer. If it's in bold, it's important. So leveled at the levostatic axis, fourth intercostal space. The right atrium. We're trying to shoot for the aortic root, like as best we can, be as accurate as possible. When you turn them to the side, mid-sternum, and then the lateral decubitus. You can also place it the external auditory meatus to try to get the circle of Willis. So when you do kind of a carotid endarterectomy surgery, you kind of really need to know much more what's going on in the brain, what the pressure is, especially when they're manipulating carotid artery here. They only have one useful. It's important to know what the pressure is, because pressure, the blood, the oxygen getting into the brain. And something we're familiar with, working in the ICU, but not the specific. So for every 15 centimeters in height, the transducer is moved up or down. There's a corresponding change of 10 millimeters of mercury in the blood pressure reading. So important to know that as well. Modification waves. So kind of measurement between the direct measurement versus indirect. Systolic pressure, 5 millimeters of mercury higher with the art line measurement versus from the cuff, diastolic, 8 millimeters of mercury lower. Obviously, we don't want any air bubbles in. Make sure all connections are tight and secure. Advantages, if it's done correctly, is obviously accuracy in the continuous display, especially for someone like hypotensive shock patients. Really get that. Obviously, the disadvantage is money. That's always the number one disadvantage. And you need the technical skill to place it. Not as easy as an IV, and you could damage their artery. So absolute contraindications. Inadequate circulation in the extremity, it's kind of self-explanatory. If blood's not flowing through there, it's going to be worthless. Raynaud's or Berger's disease, just more endovascular disease. And in there, full thickness burns, an absent pulse. If they're dead, this isn't a good time to practice putting an art line in. A little crass. But if it's infection, open up if it's an active infective site. Relative contraindications, if they're on systemic anticoagulation, arthrosclerosis, not quite so much uncontrolled coagulopathy, obviously risk of bleeding by puncturing through there. If you go through the artery and try to backtrack while you're inserting it, kind of bleed, causing hematomas, partial thickness burn, previous surgery, or graft in the area. And the ASA standard mandates every patient getting anesthesia needs to have blood pressure and heart rate determined at least every 5 minutes, and no greater time interval than that. So at least every 5 minutes there must be a blood pressure recorded.